in prior years, we have had a mock tumor board where the physicians and APPs and nurses would stay in here, and then some of the nurses and patients and caregivers went to another room, and we kind of hashed out some common topics, kind of like just collegial discussions about some cases for the tumor board. And then the shared discussions in the caregiver room was a lot of people would actually WebEx in. We're mixing it up this year, and under Elise's moderation skills, what we're doing this year is we're keeping everybody in here for this last session, for the last 45 minutes. There's no way, I think we're gonna be able to stay at 45 minutes, but we're gonna try. And we realized that we could bring both that multi-D tumor board kind of discussion and the caregiver family meetings together to talk about some misconceptions about pancreas cancer care. And also so some patients and families could share some of their journey. Nancy used to tell me that she hated that word journey through pancreas cancer. She said, so that's fine. So sorry, Nancy. I do think hearing lessons of what people have gone through are shared by a lot, and hopefully we can all learn from each other, both in the clinical and the patient and caregivers. So I want to introduce all of them. If I've talked to you about coming up or Lisa spoken to you, please come up. We're going to share these 2 microphones. We took away the tables. We want to keep this last part as informal as possible. And I really, really want to try. I mean, I see Devin in the back with his ponytail. Devin, you can even ask questions. And G, you don't have any hair. You can ask questions. I don't know why I'm focusing on hair. But I've got Jerry. I've got Elise and her sister. Jerry's a patient advocate for our ambassador program. Tiona is also a stage 4 survivor. We have Ms. DeWitt with the DeWitt Foundation, and we're very, very excited to have her with us. And I think Dr. Chaffee and Dr. Zabo, do you mind joining us? Yeah, is Dr. Chaffee still here? Oh yeah, there she is. Can't hide. And really, so once we get settled, I'm gonna turn it over to Elise, but I really want to push the audience actually to try and learn from these people, because these are experts in their fields.
We should just stay up here. Have a new one. Okay. So thank you so much, Dr. Page. I'm super honored to be here. And I really pushed him about having this togetherness, because I think there's so much that doctors can learn from patients, and we, of course, can learn from our doctors. So I will start, and then we'll go around. You tell about your particular stories. I'm going to try to do this in 3 minutes. So I'm Elise Tedeschi, and I was diagnosed with stage 4 pancreatic cancer. It was inoperable, and it was way before Dr. Page got here, and so I ended up not getting diagnosed for quite some time. Took a long time to get diagnosed. Finally got diagnosed at Moffitt in Tampa, and got this crazy news. So I ended up doing 12 rounds of FOLFIRINOX, which had just really come out pretty much the year before. And then I did stereotactical radiation along with a 5FU chemo pump 5 days a week, 24 hours a day. Did that at Moffitt. And then I had to be off of everything for a month. Then I got scans and very shocked. I had no active cancer. So all the metastases were gone. I still had a tumor in there. It was very large in the beginning, but the tumor had shrunk, but it was just not active from the PET scan. So unfortunately, it never broke away from the superior mesenteric artery, and a traditional Whipple was not an option. So ended up doing a different kind of surgery, just as invasive, called the IRE, which is irreversible electroporation or nano knife. Some people are, it's not a knife at all. But I had that at University of Louisville with Dr. Robert Martin. And today it's 11 years and 1 month that I have been no evidence of disease. So.
Andrew Page, surgeon.
Jessica Chaffee, also a surgeon.
I'm Carrie Roth. I'm Elisa's sister. I'm a 21-year survivor of breast cancer diagnosis. And I am here because I'm Elisa's, what we termed NAGvocate, combination of, well, you got it. And so I'm here to talk about the kinds of things that people like me can help the pancreatic cancer patient.
Good afternoon. My name is Deborah Davis DeWitt. My husband was diagnosed with pancreatic cancer on February 21st, 2021, and passed away September 5th, 2021. He was stage 4 and it had metastasized in multiple places, inoperable. And I am here just to talk to you about our journey and what we are doing in the future to make pancreatic cancer more awareness in the African-American community.
Hi, I'm Tiona Ducray. On April 1st of 2016, I was diagnosed with actually stage 3 adenocarcinoma, locally advanced, non-resectable. So I wasn't eligible for surgery. And I did about 6 months of chemotherapy. And my oncologist is somewhere in here. Half of my super duper team was here. And then I did surgery, and then I did more chemo. And 7 years and about 4 months later, here I am, very thankfully. And I'm here to talk about what life after pancreatic cancer can look like when we have the right research, when we have the right therapies, and when we have the right awareness. So thank you.
Good afternoon. My name is Jerry Kiefer. I'm was a patient of Dr. Page. I was diagnosed with pancreatic cancer 5 years and 4 months ago. My wife and I got into a very dark place after 3 days being diagnosed. We were discharged. I was discharged from Piedmont Henry with really no info except Google. So I was really happy with Google as far as going on there and just searching everything. Put me in a dark place. When I met this surgeon right down from me, he brought light into my life. He gave me hope that I've been holding on since. 8 rounds of FOLFIRINOX, Whipple, followed by 4 more rounds of FOLFIRINOX. Good to go. That's 5 years now. And Dr. Fleming, you were right. Exercise, stay in shape. You never know when you're going to have to come back. And I like to come back and see Dr. Page during the conference and not an office call. So thank you very much.
So I'm Steve Zabo. I'm a medical oncologist. I'm the one who asks all these questions because I like to know what people are thinking. And I just want to tell everybody, and Dr. Fleming knows this next decade is going to be unbelievable. The European Society of Medical Oncology just had their big conference. Some of the stuff I was reading was just unbelievable. We are going to be able to dissect out multiple different forms of pancreatic cancer. We will manipulate the immune system. We used to talk about chemotherapy being a thing of the past. I'm starting now to believe it probably will be the thing of the past.
Can I say something? So I noticed that when the living heroes, I don't say survivor, the living heroes told their story and there was applause, but when I talked about my fallen hero, there was no applause. His life was just as important, and I would like to see that. Thank you.
Could I ask a quick question? It'll help, I think, all of us respond. Of the people left in the room, how many of you are medical professionals? And how many of you are patients or family members or caregivers? Very good. Thank you.
Can I talk on this? So one question that I have is that I know in the beginning when those of us being diagnosed or our loved one was diagnosed, that words are really powerful. For me, my doctor had told me, I did ask him how long I had to live, but he also kind of followed up by, you are a statistic of one. He also told me I could work, which I did, and I lived my life during chemo. So whether or not I was going to live or not, essentially, or get through this, I had 2 little boys at home, kindergarten and 2nd grade. So I just love to hear from all the survivors of something that your doctor said, negative or positive, and how it kind of set that tone.
Well, I would like to comment. Well, I think I alluded on it just a few minutes ago. When my wife and I went to see Dr. Page for the first time, he looked at me and he said, "I've got a plan. You can have surgery." And the confidence that came about him just filled the whole room. So I would say, Elise, it was the hope that my surgeon, Dr. Page, gave me, and that hope I've been holding on to for 5 years and 4 months, and I won't let that go. So that was the good thing. I can't think of any negative, not right now, except for maybe the beer you had last night. You could have got the Michelob Light.
Sure. So the things that doctors say to their patients and how you say them, I cannot emphasize enough how critical that is to how the patient views the disease and how we view ourselves through this. And it's critical, and I would say not just for the patient, but for everybody involved. I think even as the physician, what you're saying to us, do you believe it? My doctor, my surgical oncologist, Josh Weiner, he looked at me and he said, "Hey, you're 41 years old." And he said, "This is bad, but," and he said, "I think we can do this." He said, "I think one day you're going to be 80 years old." And I was 41 at the time. And he said, "We're going to look back on this and we're going to laugh at this crazy thing that happened the day you came into my office and had pancreatic cancer. And we're going to kind of reminisce about it when you're 80 years old." And I was counting in my head, I'm not the best at math. And I was like, wait, that's like a really long time. That's more than the 21 months than everybody was saying that I was going to live at the time because I had stage 3 pancreatic cancer. That went such a long way for me. And I'm still counting down. I'm turning 50 next year. So got like 30 more years to go, right? To make good on that promise. I think the other part of it is that not only did I believe it, my doctor believed it, but my family believed it. And everybody around me was cheering for me based on the thing that my doctor said, was that he believed that there was hope enough for me to fight this disease. And there was. So I would say, really think about that. What you're putting into your patient is not just the will to fight, but it's the hope to live also.
For me, even in my husband's diagnosis, and his diagnosis was very aggressive, that hope was still there, right? With the doctors. They were still going to do whatever they could to ensure that he can live as long as he could. And to your point, having that hope and making sure that you are talking to your patient in a way that is hopeful, and that just helps a lot.
I'm reading from Good to Great, and he talks in there about the Stockdale paradox. And Stockdale was a Vietnam veteran who was a survivor of the camps there, and he talks about who are the people that survived the internment there in Vietnam. And he said the paradox is the people who retain faith regardless of some very dire circumstances, but we're still face the harsh facts. And so the guys who thought we're going to be out by Christmas didn't happen. We're going to be out by Easter didn't happen. They're the ones that kind of lost their way. And so to the doctors, it's so important. What Elise didn't tell you is, as we went around and got answers from everywhere, there was a doctor at a well-known cancer center who said, you know, if I were you, I would stop chemo now, have good quality of life before you die. And if you survive this, it's not going to be because of what any doctor did for you. And so for the patients out there and for the doctors need to hear it too, you gotta be strong in your own sense and make your own decisions, have that conversation, come prepared to those meetings to ask the hard questions, but also to understand what hope there is out there. I think Dr. Fleming, what you've talked about is for buying some time as this ship turns. I mean, when you're looking at the stats of this disease, it's based on long history. It's like turning an aircraft carrier, but the science is moving not at speedboat space, but it's moving faster than that. And that I think is the kernel of hope that is out there for everybody.
So it's a great segue to the doctors. How do you balance hope and statistics?
Thanks. I think that you have to look for
Hold it up closer.
where the patients and their families are coming from first and foremost, and you have to listen to see where they are in their journey and what they are willing to hear. So if they've just come into your office and this is the first time anybody has told them they have pancreatic cancer, it's a very different discussion than if they're coming back a couple weeks later after having a lot of time on Google or so forth. So you have to meet them with where they are. And unfortunately, nobody teaches you any of this in your training to how to have these conversations. And so in the very beginning, patients would ask me, well, how much time do I have? And so I'd give them those average statistics and I'd say exactly what they said to you, that those are just averages and that doesn't, necessarily apply to you. But as time went on, I've found that the non-answer is much more informative and provides a lot more hope to those patients. So instead of telling somebody, well, on average, patients with stage 4 pancreatic cancer, die within 6 months, I will phrase it to them in a way of that they are a unique individual, that we have to decide what is important to them. And kind of borrowing on what Dr. Jackson said earlier, is balancing where their goals are and what their overall goal for treatment is with the potential morbidity of what we're going to do to them.
Yeah.
It's a hard question. I first of all, words have a lot of power, and I'm generally, I like to think I'm very careful with patients about words that I use. I also want to be careful not to put my value system on them, but listen to how they value things. The one thing I do try to do for patients at the beginning, because I'm a patient, I have illnesses, and when I have them, I don't feel in control of my body or in my life. So I try to, best I can, give them control back. Isn't that what we all want, really, is to control our body? And I think when a patient asks me, what diet can they do? What exercises can they do? What they're really asking is, what can I control? What can I do? Because it's about control. So we work on control. And then depending on the disease itself, I don't beat around the bush about statistics. I do talk about them. But like everybody else, every individual is different. I gave you a story of a person who I blundered into doing a radiation thing and cured him, not because I'm a genius, just because he really lucked out on that one and stuff. But so I do talk about statistics, but also people often ask me, why, oncology, how do you do this? Your patient, many of your patients die. Many of my patients more live than die, but I don't really think of it that way. I'm sorry about your husband passing away in 2 years, but the reality is 2 years, he got to do some cool things, right? And so when I'm with a patient who we know what the end is going to be, if we get them to these milestones or things, that's awesome. That's life. And I think we should rejoice in that. So it's probably not a great answer, but it's just kind of my answer. So.
Dr. Page?
Yeah, I obviously agree with what everybody said. I think and I'm curious, I'm looking at a couple of my patients out in the audience. I'm wondering what they think about that. But what I try to focus on are, just like others have mentioned, things you do have control over and really take advantage of those. If you can walk 5,000 steps a day, keep that going. Put it on your phone and walk 5,000, walk 6,000. But I also think it's really important, for at least my personal practice, to really highlight that we have a plan. And when I first started, actually, I stole this from Doug Evans, was, hope through a plan. Everybody's plan is different, but with that plan, and personally with my own family, we felt that the same. Like, you know what the plan is, because the unknown is what really bothered my family when we were going through oncology cancer diagnosis. And I try and share that with my patients, is that we stick to that plan. The plan can be fluid, and it has to be fluid, but we've got to have some type of framework to stay on track. And as cliched as it is, I really, really believe that just the perseveration on the fact that you just got to take it one day at a time. You don't look ahead. I mean, everybody who's been in my clinic sees me right on the walls, all over the place, right on the ceilings, the windows, but it's, what is it? What stage is it? And what's the plan? What is it? What stage is it? What's the plan? There's so many details that we can just get overwhelmed with. And I think that information overload can be really harmful, especially inaccurate information, but even accurate information can be just drowning sometimes. So I really try to focus on that plan, taking one day at a time, and keeping your scope of what you can understand, to really keep moving forward. And Joey, can we do something about the screensaver?
I wanted to echo that. It's and maybe in this facility you have good communication between all of the medical subspecialties, and I'm hoping that conferences like this can be pebbles into a pond, that people are going to go out to their different communities. The patient survivors are going to hear from friends in faraway places, and they're going to ask for advice. That worst period for any patient is not knowing even what the plan is. Once they have a plan, putting their head down and marching is so much easier than that twilight zone of not knowing.
Yeah.
Can I ask a question? This is for Dr. Zabo, and I'm curious what the other patients think. A question I get a lot of is, I'll see a patient, they've gotten their 2 or 3 cycles of chemo, and occasionally they'll say, Doc, I feel pretty good. Is the chemo working? So I'll turn that to you.
Yeah, so that was, that's goes back to the palliative care doctor. You know, I tell patients, I'm not giving you chemotherapy to make you feel bad. I'm giving you chemotherapy to make you better. And quite honestly, if the therapy is working, they should feel better. Now, there are some side effects, but if the side effects are so overwhelmingly bad, then I'm doing something really wrong and I need to change that. So I try to make sure that people realize I am not giving treatment to make people feel bad. I'm trying to make people feel better. If I am making you feel bad, then something is wrong. Then I need to fix something.
I would say from a patient perspective, I mean, I got down to 89 pounds, pretty bad neuropathy. I was still walking, still getting dressed, I was still working, very chemo brain. But I kept telling my doctor, no, I got this. I'm okay. And I remember the last few rounds of chemo, they were like, we want to not give you the full blast. I'm like, give me the full blast. I'm good. And I just, I think everyone has a will to live, but I mean, my kids were kindergarten, second grade. So I was just like, no way I'm leaving my boys. I don't care what I got to go through. And I was willing to take that on. I mean, didn't matter what I ate. My navigate over there would be like, no, you need to eat this, that. I'm like, doesn't matter. But
I think you kind of summed it up. It's a team decision, right?
yeah,
That's what it is. It's a team. I mean, honestly, managing, treating, taking care of people with malignancies is a team sport. It's not the doctor. Doctor's one person. It's the nurses, the nutritionists. It's the patient's family. It's everybody. It is a team sport. Nobody does this alone.
I think on that same note, there's a couple of things that I would say. Having the plan is really important. So I wasn't going based on how I felt. I was going based on the actual data of what was happening. The tumor was shrinking. I knew I was going to have scans so many rounds. I knew that I was scheduled to go into surgery if the chemo was working. I knew that in order to be eligible for surgery, the tumor had to shrink by so many centimeters for me to even get to that point. So it was less about how I was feeling, because honestly, I was feeling really crappy, no pun intended. It was chemo was not fun, but what my medical team did, and to your point, Dr. Szabo, it was a team sport. My nutritionist, my surgeon, my medical oncologist, my family, my caregiver, everybody, we were all talking and we were working together with the goal that we got to get her to surgery. And we knew exactly what that looked like. So I think the communication piece of it is really important. And communicating with the patient is really important. So we're not just kind of going on, oh, I don't feel really great, this isn't working. I could look at the scan and see, okay, the tumor is shrinking. I know it's what is supposed to be happening is happening right now.
just quick to side note, I know that side effects are not indicative of how well or how not well the chemo is working. So some people can have tons of side effects. Some people can have none, and it could be working or not. So it's not indicative of it.
I'd like to make a comment on that. And by talking to patients for the past 3 years on that, being an ambassador, and we do Zoom calls every week, I see that so often that the chemo affects everyone differently, so differently. If I get neuropathy or I've got nausea, that doesn't mean that the other patient's going to get it. I always looked at it that, hey, if I'm feeling sick and my toes are tingling, I know that oxyplatin's kicking in and is working. That's why I said, but as far as the team, everyone with the experience that I had with my oncology team, the infusion nurses, they all clicked together. With the surgery team, they were all one. And it was just the healthcare professionals and the doctors we aren't doing this alone. I've never felt alone. I know that all you doctors are out for us, trying to give us longer life. And I really appreciate it. And I'm going to make y'all proud. I'm 71 now. I've got about at least 10 more conferences to be here. I am going to be the record breaker. I'm right behind Elise.
We need more.
Thank you.
Come on. So this is a question to the doctors. Say you're at a point where you're sort of out of options. You're thinking, when are you thinking outside the box? When are you maybe suggesting a trial? Like, when do you not have the answers? What's your go-to? I'm sure it's different in every situation, but typically, what is that?
Yeah, so I'll start. A common, not common, but I'd probably say every other month I'll have a patient where it looks like the chemo hasn't worked. And when I say it hasn't worked, I mean that they've blossomed or the tumor's grown. When that or it's gotten to the point where I don't think I can safely remove it, and we need to change plans. Oftentimes I'll recommend a second opinion, not just because I'm trying to put them on someone else, but so that they feel like they're getting all of their options, all their questions answered. But specifically when it comes to trials, I think it depends on the type of trial. The surgical trials are, obviously not as common as medical trials. So Zabo will have a better answer for that. But I think you just have to be honest. When things aren't going well and you need to regroup, you just put it out there and say, I don't know. I mean, Tevye said it when he was up here for that case. And I think there's some just genuine honesty in that. You just have to regroup and restage and get back to what stage is it, and what's the plan now?
I just want to make one quick comment, is that having numerous different opinions, it kind of blew my mind seeing that each doctor really had different thoughts. And granted, this was essentially 2012, so it was different. But I felt like there was such a lack of communication between doctors in general. I'm BRCA2, and when we talked to this one doctor at another hospital, I don't think anyone's here from there, that doctor was like, I don't care if you're BRCA2. And essentially he didn't read a trial that they had in France. So do we help you at all with that? I mean, how do you guys learn even more of that? And we can go back to the other question as well, but I just think that it was just mind blowing to me.
I think that the time to think outside the box is with every single patient, right? Because there isn't, although we have our algorithm and we have our tumor board approach that we go through, we are always trying to think outside the box. And so every single patient, every family, every diagnosis is different. So there isn't a one fits all approach. And as far as your other question, I'm always eager to learn more, because I can in zero ways keep up with all the literature that is out there. There just isn't enough time in the day. So any studies that patients have or family members have or medical oncologists or anybody else has to bring to us, I think is always welcome.
Yeah, it's great.
So I don't really, this is how I talk to, so my patients ask me at the beginning, what is our plan? And I always tell people, when you're dealing with cancer patients, I think in medicine in general, because I used to be an internist as well, just general internist as well, it's a game of chess, not checkers. So I don't think one move ahead. I think many moves ahead, because if you think one move ahead, you may burn the bridge for something that was very important, like a clinical trial or whatever. So, does it come to like the end and I have to think of things. I don't really generally think of it that way. I definitely query my colleagues a lot. I always encourage second opinions, third opinions. And when it comes to the point where, quote unquote, there are no more therapeutics, that's never actually true, because when you talk to the palliative care physicians who, if you have the opportunity, I wasn't trying to give the palliative care doctor a hard time, but not every community has palliative care, but you just focus your attention on more sophisticated supportive care and stuff like that. So I like to think I'm a rational thinker, not an out-of-box thinker. How's that sound? Okay.
I think that is awesome. So I'm sure we've got some questions out there. Anyone? Wait, you got one. Oop.
This is a compliment, not a question. My doctor is Dr. Page. And I got diagnosed January 9th this year. Of course, we cried. We went on the stupid internet and oh my God, it's over. January 9th, within January 20th, I was getting my first chemo. Anyway, when we went into Dr. Page's office, he came into the room and he said, "Why are you here?" What a great question. And I told him why I was here. I have pancreatic cancer. And he says, "I have a plan. We're going to beat it." And he goes to his famous whiteboard. I believe it's a erasable marker. And he drew the picture of the pancreas, showed me where my tumor was, and wrote down what we were going to do, so many chemos. And the relief of my wife and myself was overwhelming. So we had a plan, and that doom was gone. So anyway, we have to drive back to Florida. I enjoyed this. My wife and I enjoyed this tremendously. And I want to thank everybody, all of you people up there, everybody, all the speakers were great. And I just wanted to compliment Dr. Page and his staff and all the nurses in chemo. They were fantastic. So thank you very much for inviting me.
All right, so I'm going to ask another question to this panel. Whoever can start. So what frustrates you the most? Whether it's doctors about patients or patients, caregivers about anything along the way that really frustrated you, and that maybe with this group that we can change things.
I'd be happy to start. From my own experience, my sister's survivorship has been out there on Facebook. And so people call me when they get diagnosed. And so I've helped many people through this. And often, they're in smaller communities where they don't have the kind of resources but they'll get, so there's two things that have frustrated me in this. One is the doctor who doesn't know what he doesn't know and then poo-poos the things he doesn't know. I'm sorry, it's almost always a he, but it's, and that's just something that has to change with education and getting the word out there to your average small town GI doctor. And then, the other thing is, and sort of related, is the fighter pilot mentality surgeon. Oh, I can do that. I have two friends that, opened people up and then discovered, to you, Dr. Sachs, just because you could, maybe you shouldn't have, so people ended up recovering from unsuccessful surgeries and then putting them a step back. So those are my pet peeves.
For me, when my husband and I were going through our journey, my husband had He had an issue with his gallbladder. He had acid reflux. So he was seeing his gastroenterologist regularly. And so he went to see his gastroenterologist the beginning of February about his gallbladder. And the recommendation is to remove the gallbladder. And then he had a colonoscopy. Colonoscopy was clear. And 3 weeks later, he was diagnosed. What was frustrating to me is I just saw my gastroenterologist, right? We just saw him, and it wasn't top of mind. Maybe he wasn't aware, but that was very frustrating for me.
So I think one of the most frustrating things for me, when I got diagnosed, the survival rate in 2016 was 7%. The survival rate for African Americans was less. Not only was the survival rate less, the occurrence rate was higher. So more African Americans, more people that looked like me were getting diagnosed, and more were dying without any real explanation. When I went in, I was actually told by the first doctor that I saw, this is definitely not pancreatic cancer. You're 41 years old, you're young, you look perfectly healthy, you don't have any family history. It's spring break, go home, have a good time, come back in a couple of weeks, and my colleague will see you who deals with this more than I do. Had I not have gone to a doctor immediately, I don't know that I would have been sitting here today. My mom was the one that said, I don't like it. You need to find somebody else, and we need to figure out what's going on. I was losing weight. I had horrible back pain. My stomach was hurting. I just didn't feel good. And I was willing to walk out of that office and go have a great time on spring break. The frustrating thing is that when I finally did get diagnosed a few weeks later, I was told the only real marker that I had was that I'm Black. That was the only thing that made me more susceptible to pancreatic cancer at 41 years old. They couldn't pinpoint anything else, nothing in my biology, nothing in my behavior or habits. I wasn't a smoker, nothing. I didn't have diabetes. I wasn't overweight, but I'm Black. And that makes me more susceptible. So when we lose Eric and many, many other African Americans in this community at a faster rate than anybody else, that's frustrating to me.
+1.
That's one. Yeah.
Yeah.
Very, very frustrating. And being able to, I created the foundation in my husband's honor so that we can bring that awareness to this community that does not necessarily have the access. And so that we can be our own advocates. When we're seeing doctors who say, go on spring break, no, there's something going on. My husband always knew something was going on, but really just finding the right doctor and being able just to advocate for yourselves as patients and talking to your doctor is just incredibly a great relationship. It's a collaboration, and it's a team sport, and it's a collaboration. And being in this community where you don't necessarily have that access is frustrating as well. So that's why we do these things, right? So that we can get that awareness out.
I can't think of anything negative against the doctors. I could probably think about it. My negative experience might have been the food in the hospital. It really sucked, but I couldn't eat much of it anyway. They did keep the, I mentioned to you that the tumor blocked my bile duct, and I was slushing a whole stomach full of bile in me. So they had a tube in a bag for, I thought was only going to be a couple days. It ended up being in there 7 days, and I had to make a trip to the ER because my kidneys just about shut down. I was getting kind of low on fluids. But other than that, no, no, I don't know if I ever told you that story, Doc, but yeah, I did. Yeah. But I just, unlike my fellow warrior right here, I was not living a very clean lifestyle. I was a smoker, heavy smoker for the 20 years I was in the military. Then I quit, and I'd social drinker. but I did probably a lot of the things that I probably shouldn't have done to stay away from pancreatic cancer. Of course, I'd never heard too much of pancreatic cancer until I got diagnosed. I knew that Patrick Swayze had it and Michael Landon, and my sister, who was very open, and was a registered nurse, by the way, when I had told her that I had pancreatic cancer, she, on the phone, she lives down in Florida. She said, "Oh shit, bro, you got the death sentence." But, you know, that was my sister. But I found out that when I met Dr. Page, I didn't have a death sentence. I'm still here. So thank you.
All right. I think we're wrapping it up, but I think this is great conversation. I think that we should all be doing this more often. I think it's huge thanks to Dr. Page for putting this together and having all of these great minds together. And I would tell you, I definitely want to do a big shout out to all the caregivers and all the patients, all the doctors, especially the nurses. They know everything. So
At the 5
thank
South,
you.
we got a lot of the nurses in the back. Nurses, right? If any of the nurses are in the audience, could they raise their hands? Any of the nurses? Yeah. Wow.
As a patient, nurses, y'all saved everything. They knew the answer, the solution to everything. So we know how amazing you all are. So thank you.
Thanks, everybody. See you next year. First weekend of November.